afternoon, everyone. We're going to talk about the role of 3D echocardiography in transcatheter structural heart disease interventions. Hopefully, by the end of this talk, I will convince you that the use of 3D echo is very useful in planning and guidance of transcatheter interventions. Closures. I'm a huge fan of our Houston Methodist DeBakey educational channel. We have 17,000 subscribers. Subscribed yet? Today is the day. I'm also a tweeter, and these are my favorite hashtags and handles for structural heart interventions. All right, this is our roadmap for today. This is a 3D view of the mitral valve, and this is a surgical view. That's the surgeon's view. The aortic valve is usually placed at the 12 o'clock mark, and that's the anterior position. So aortic valve is anteriorly. Left atrial appendage is lateral, and I remember it by memorizing the letters. And the interatrial septum is medially. And this is how you determine where the anterior leaflet is, being closer to the aortic valve. And this is how you determine which scallops are medial. A3 and P3 close to the septum, A1 and P1 closer to the left atrial appendage. And you see a Watchman device right here, just to guide us. It's important to remember that in order to get optimal 3D views, we have to get optimal 2D views. So to get nice 3D images, you really need good 2D images. And the way to do that is to optimize your 2D images by adjusting your focus, adjusting your depth, making sure you have your structure of interest in your 3D zoom box. Once you hit the 3D zoom, you tip over the aortic valve to the 12 o'clock position, and this way you can be looking at the surgical view that we just talked about. For example, this is a 3D surgical view of the mitral valve. This is the aortic valve right there, so this is anterior. The appendage is here, the septum is here, and you can see that part of this posterior leaflet is flailing. This is lateral, so this is P1, this is P2 in the middle, and this is P3. So this is an example of a P2 flail. And if you add color to this, let's see, you can see the jet coming from that same spot where you have the P2 flail. Now, how is 3D echo important in procedural planning? This was a patient who was referred to our valve clinic for evaluation for a mitral clip procedure. He had an outside TTE with no use of 3D imaging, and it reported a P3 flail, which we could obviously see. When we did our 3D imaging of the mitral valve, in addition to the P3 flail that you see here, again, this is medial, so this is your P3, and you see that flail segment, there was also evidence of an anterior leaflet cleft, and that changes the procedural planning and the feasibility of placing a mitral clip in this position. So the 3D views played a major role in determining the planning of this procedure. Reliance on TD views is not always adequate. This is a recent paper published last year by JACE. They evaluated about 1,000 patients with moderate to severe unexplained mitral regurgitation by 2D views. About 600 patients had 3D TEE looking at their mitral valves, and about 3.3% of these patients had mitral clefts identified on 3D echocardiography. And again, this has implications, especially when you're considering transcatheter mitral valve repair options. Let's talk about the mitral valve repair with the mitral clip. Again, why is the use of 3D echocardiography key in pre-procedural planning? This is a table from JACC Imaging, published last year, and it tells you what the most feasible anatomies are for a mitral repair, and what are the more challenging anatomies. And it's all based on 2D and 3D imaging. If you're dealing with P2A2 pathology, that's considered more technically feasible as compared to dealing with medial or lateral pathologies or severe Barlow disease, which is more diffuse. If you don't have any calcifications, that's usually favorable. And if you have severe calcifications, specifically in the leaflets that you want to grasp, that can lead to technically challenging scenarios. If you want to put a mitral clip in, you want to make sure that your mitral valve area is more than 4 centimeters, and I'll show you how we can get that by the use of 3D echo. Because if you're starting off with a smaller valve area, then that will increase the risk of developing mitral valve stenosis related to the use of a mitral clip. Favorable anatomies also include a flail width of less than 15 millimeters and a flail gap less than 10 millimeters. If you want to get a good 3D mitral valve area, you want to make sure that you measure it at the leaflet tips of the mitral valve. Using the 3D software, you center the mitral valve and go to the level of the tips, and then you can get a very nice short axis view of the mitral valve, and you can do your calculations from here. Again, if the area is more than 4 centimeters squared, that's a favorable anatomical marker for a mitral clip procedure. If it's less, then there's a risk of developing mitral stenosis if you deploy a clip. And again, 3D echo is important to determine the etiology of MR, because as we said, if it's an A2 or P2 pathology, then that's less technically challenging when you're doing a mitral clip procedure. So based on this view, you can notice that the pathology is a flail P2. This one shows a P1 flail, P3 flail closer to the septum. So this will be a more technically challenging mitral clip procedure. This one shows a functional mitral regurgitation patient. You can see that there's annular dilation. You can appreciate that the posterior leaflet is tethered, and you don't see any prolapse or flail segment. So this was a case of functional MR, and nowadays, after the COAPT trial, we're doing more and more functional MR cases. All right, we've talked about planning mitral interventions. What about aortic valve interventions? This was a patient who came to our clinic with severe aortic stenosis, but had very advanced CKD with a severely reduced GFR, was claustrophobic, had a device, so we couldn't do a CTA or an MRI to get annular dimensions pre-TAVR. So what we did was a 3D echo to determine the annular measurements, and similar to the previous mitral valve anatomical characterization, you want to include your field of view, and then by using the 3D software, you can get your annular measurements, you can get your coronary artery height. And recent studies have shown good correlation between our 3D echo measurements and CT. So this is useful in patients who are unable to get a CT or an MRI for TAVR planning. In this same patient, because we're trying to protect the kidneys as much as possible during the TAVR, we used CT fluoroscopy fusion. That's a different patient. So that patient had a CT actually during the time of the TAVR procedure, a dynamic CT. We got the annular markers, and we can overlay the CT markers on the fluoroscopy to aid in valve deployment with minimal use of contrast. All right, we talked about procedural planning. Let's talk about procedural guidance. And 3D echo is key in procedural guidance, especially for mitral interventions. Let's start with the transseptal puncture, which is not only used in mitral interventions, but also in EP procedures and left atrial appendage occlusion procedures. Historical perspective, transseptal procedures have been performed since the 1950s, initially to measure hemodynamic LA pressures, especially in patients with mitral stenosis. This was followed by percutaneous balloon mitral valvuloplasties in 1984, followed by pulmonary vein isolation for AFib in the 1990s, followed by left atrial appendage occlusions, percutaneous left ventricular assist devices, PVL closure, mitral clip or percutaneous mitral valve repair, and most recently, mitral valve-in-valve implantations and transcatheter mitral valve replacement. So the transseptal puncture step is a very critical step because each procedure requires a certain precise location for the transseptal puncture based on the trajectory of your of the catheters that you would need to ensure procedural success. And spending time during the procedure to get your ideal transseptal puncture is key. This is what we use in the cath lab when we do a transseptal puncture. We use biplane 0 to 45 degrees to determine the anterior aspect of the septum and the posterior aspect. If you see the aortic valve, then you're anterior, and then you'll have the anterior posterior direction. And then for the bicaval view, SVC and IVC, you get your superior inferior orientation. And again, biplane enables you to see the septum in two orthogonal planes to make sure you're puncturing at your ideal puncture site. We've been using a lot of 3D imaging of the septum and the fossa ovalis. Changing the gains during imaging can be critical because you have to get the ideal gain where you can see this clock face for the fossa ovalis. And again, different procedures require different puncture sites based on the trajectory of the catheters anticipated. During the transseptal puncture, you start by guiding the interventional cardiologist to your ideal transseptal site. After that, you would measure the distance between the transseptal site and your mitral annulus if you're performing a mitral procedure. Ideally, you'd want it to be about 4 centimeters in a mitral clip procedure. After that, and before they perform the actual puncture, you'd ask them to tent with their needle so that you can see it on echo and confirm the location. For mitral clip, you want to be superior and posterior. So they tent, and we go to our 3D views, and we can see them tenting right here at about 1 o'clock. This is your aortic valve, this is your mitral valve, and this is your medial commissure. So you're right above the medial commissure, and you can see them tenting. Once you confirm the location by 2D and by 3D, then you can watch the transseptal puncture procedure live on 3D. For some reason. And this way you confirm that you've crossed the septum, you're not tented, and you're actually in the left atrium. Let's talk specifically about guidance of a mitral clip procedure. This is a patient who presented with significant shortness of breath with minimal exertion, had a TEE, which was notable for severe mitral regurgitation, and you can appreciate the flail gap right here. It's pretty significant. Again, 3D imaging shows the pathology beautifully. This is your aortic valve, your appendage, and you have a flail P2 segment. And you can see it here as well, with significant MR. After you perform the transseptal puncture, you advance the delivery catheters and the mitral clip to the left atrium. Once you advance it to the left atrium, you want to flex your catheter to make sure that this clip is positioned right above the mitral annulus. But to do that, 3D helps you in clearing this clip from the Coumadin ridge. So this is your Coumadin ridge. The last thing you want to do is start flexing your catheter when the clip is touching the Coumadin ridge. So you tell the interventional cardiologist to either withdraw or advance the clip to make sure that you've cleared the Coumadin ridge, and then you can flex the catheter so that the clip is positioned right above the mitral annulus in the left atrium. 3D is very helpful because any manipulation of the clip in the LV can lead to, the clip can get entangled in the cords. So we try to optimize the clip position in the LA under 3D guidance, and then from there we advance to the LV. At that point, we require minimal manipulation in terms of the clip position. So we determine where the pathology is. With 3D echo, we make sure that the clip is centered right above our pathology. And then we advance the clip into the LV. So you can't see it here. You see the tip of the catheters, and the clip is now in the left, left ventricle. Once we're in the left ventricle, we go to a long axis view, and this is our grasping view. We use 2D imaging to make sure that our clip is still centered in, positioned right above the pathology. In this case, it's a P2 flail. You apply some color to make sure that you're in the jet, so that when you grasp both leaflets, you expect the pathology to be reduced. So you confirm the position of the clip by 2D and by adding color. You want the anterior leaflet and the posterior leaflet both to lie on the clip with enough leaflets in that V space to make sure that once the clip is deployed, that there's a good grasp of the leaflets. Otherwise, if you're only getting a side bite or if you're getting a small piece of the leaflets, that can lead to risk of leaflet detachment eventually. So you confirm the position of your clip by 2D. You make sure that there's enough leaflet going into the clip. You make sure you're in the jet, and then after that, you close the clip. And reassess your mitral regurgitation degree. Make sure there's a reduction in MR. At the same time, it's important to assess your gradients. Sometimes if you deploy a clip and you get a huge MR reduction but a high gradient, that leads to mitral stenosis, then you'd have to move the clip or go for a smaller clips. We currently have 2 mitral clip sizes. So after you deploy the clip, it's important to evaluate the degree of residual MR and the transvalvular gradient to evaluate for MS. And that's why it's important for baseline imaging to have a 3D mitral valve area, because if you're starting with a mitral valve area more than 4, then the risk of developing MS after a clip is deployed is much less. Again, 3D is very useful in ensuring that you have a good tissue bridge between the 2 leaflets. So you can see this clip going between P2, where we had the P2 flail, and A2. So there's a good tissue bridge, and you can see that the clip is stable and not moving freely. And if you add color, you see that there's minimal MR laterally. This is your appendage, this is your aortic valve. So color, 3D color is also helpful in evaluating residual MR. It's important to look for hemodynamic objective measures of success. When you start with severe MR, you have systolic flow reversal in your pulmonary venous flow. After a successful clip procedure with a reduction in MR, you have an upright systolic wave. Correspondingly, you have an increase in your LVOT stroke volume. And these can be found in the newest guidelines published this year by Dr. Zogby, tackling the evaluation of residual regurgitation after transcatheter interventions. Again, for the role of 3D echo in post-procedural follow-up, this was a paper published by Dr. Little and his team. Because oftentimes after a mitral clip procedure, you can end up with multiple jets, and it's challenging to objectively quantify the amount of residual regurgitation. One way is to calculate the vena contracta area of multiple jets and add them up. And this study has shown that a vena contracta area of more than 0.27 is suggestive of moderate or more than moderate residual mitral regurgitation. This is important, especially in the procedure room, because you want to know if you need to move your clip slightly to establish a lower degree of MR, if you need to deploy additional clips, if there's a gradient room for you to do that. All right, we've talked about the transcatheter mitral valve repair options. We'll say a few words about the transcatheter mitral replacement and the role of 3D echo. Mm-hmm.
What is the role of fluoroscopy during all this manipulation that you talked about?
So fluoroscopy is...
You're not doing any fluoroscopy? Is everything guided by 3D?
I think we do minimal fluoroscopy, of course, advancing the catheters and the wires. But in terms of positioning the clip, it's all 3D guided. Before we place the catheters into the LA, we make sure that there's a wire in the pulmonary vein, and this can be visualized by fluoro in terms of the trajectory of the wire, but we can still view it on 3D. So the use of 3D, I believe, significantly reduces the fluoroscopy time of the procedures. All the leaflet grasping, positioning is all echo-guided. After the clip is deployed, fluoroscopy is used to make sure that once the clip is released, it's stable, and it guides the catheters outside of the septum back into outside of the heart. Okay. Transcatheter mitral valve replacement can either be a valve in a native valve, which is the most challenging of all these procedures because the mitral valve annulus is very dynamic. Valve-in-valve procedures where you have a dysfunctional bioprosthetic valve, and a valve-in-ring where you have a pre-existing mitral valve ring. Valve-in-MAC is less commonly performed and is definitely more technically challenging as compared to the previous 3. This was a 65-year-old lady who presented to our clinic with, again, severe shortness of breath, fluid overload symptoms, had a history of bioprosthetic surgical mitral valve replacement, an outside TTE, showed some regurgitation, high gradient, and she had a TEE for further evaluation of her biprosthetic mitral valve. On these views, that you can see that one of the leaflets is kind of flailing, this one. And there was MR associated with this dysfunction in her biprosthetic valve. Again, it's very helpful to look at the pulmonary veins. If you see any systolic flow reversal, that's suggestive of severe mitral regurgitation. So this was a patient who had severe COPD, had a history of cancer, had radiation to her chest, was evaluated by the surgical team and was deemed to be at a very high surgical risk. So all these patients who eventually present for transcatheter interventions need to be evaluated by a surgical team to determine their surgical risk. So she was extremely symptomatic with a dysfunctional biprosthetic mitral valve at a high surgical risk. So we started the planning phase for a transcatheter mitral valve-in-valve procedure. And CTA is key in this procedure, first to evaluate the function of the prosthetic valve, and second of all, to try to predict any potential complications from the valve-in-valve procedure. This is more so in the mitral valve and native valve procedures, but can still hold true in valve-in-valve and valve-in-ring procedures. So she had her CTA, and the CTA helps us establish the internal diameters of the biprosthetic mitral valve. And then we have a mitral valve-in-valve application, which you can all download on your phone. If you know the size of the prosthetic valve that the patient has, and you have the diameters and the size based on the valve that they had, this application will tell you which transcatheter valve can fit in this biprosthetic valve. And that's important when you're planning a transcatheter intervention. You want to know which valve you're going to use because this procedure involves a transseptal puncture and transcatheter valve deployment. So this patient underwent a SAPIEN 3 valve implantation in her bioprosthetic mitral valve. And again, we start with a transseptal puncture under echocardiographic guidance, followed by advancing the delivery system into the valve. You want to make sure that the delivery system is going straight into the bioprosthetic valve. This is your transseptal site, and this is your catheter, and this is your dysfunctional mitral biprosthesis. And then a balloon is advanced. This is a balloon expandable valve. So again, you confirm the positioning of the transcatheter valve in the biprosthetic degenerative biprosthetic valve. You can see it on 2D and 3D. And then once you confirm the position, the valve is deployed. You can see that the balloon is being expanded. You want to make sure to evaluate the valve right after its balloon, after its expansion. If there's significant PVL or if there's significant MR, then sometimes you have to re-balloon the valve. So this was deployed. And again, you can also see this on 3D. This is the balloon being expanded, and now the valve is deployed right here. This is post-mitral valve-in-valve assessment of the new transcatheter valve. What you look for is any PVLs, any transvalvular MRs, and again, any gradients across the valve, which are likely to be elevated in the setting of a new transcatheter valve. And 3D really helps you look for these regurgitant jets. So this patient had trace central MR, maybe a touch of PVL here, but nothing significant. So nothing had to be done about this valve. And the patient did really well, came back for follow-up, did not have any shortness of breath, and did very well. Again, we don't have very long-term data on using these valves. So again, whenever you have a patient who's symptomatic, it's with degenerative biprosthetic valves, it's important to evaluate their surgical risks, because if they are at a low surgical risk, then that would be the option. Again, fluoroscopy. This is a second case of a severe functional MR. This was before the times of the co-op trial and before it was approved, the only way we were able to treat the functional MR patients was either through enrolling them in transcatheter mitral valve replacement trials or the co-op trial. So this patient had ischemic cardiomyopathy, severely depressed EF, again, very symptomatic, medically optimized, seen by the heart failure team, is on guideline-directed medical therapy, but continued to have significant MR. So the plan for this patient was a transcatheter mitral valve and native valve with this Intrepid valve. There are different transcatheter mitral valve devices with different designs. The common goal of these devices is to be able to anchor well in the mitral valve annulus. It's very dynamic. It has to withstand the LV systolic pressure during systole. They can either use a radial force to stabilize themselves in the mitral annulus. Some of them have apical tethers that go into the LV, but they have different designs and are being studied under different trials. This is a procedure that's done in the OR using a transapical puncture. Again, TEE helps guide the surgeons to the optimal ideal transapical puncture site. So you have a biplane TEE image, and this is the surgeon after they're done with their surgical cut down, poking at the apex with the echocardiographer confirming the position of the transapical puncture. And I was able to see it here on fluoro. I guess this is Dr. Reardon, you can tell. Okay. Once you confirm the position of the transapical puncture site, then the delivery system and the valves are advanced into the LV and then into the LA. And it's important to have all your pre-procedural images reviewed because you want to make sure you're crossing at an angle where you're not risking injury to the RV apex or to the subvalvular apparatus. So that's where CT can be very helpful in pre-procedural planning of TMVR procedures. And this is by fluoro. You're advancing the Intrepid valve into the LV. Now it's opened in the LA. After that, it's deployed in the mitral annulus, and you want to make sure it's stable. You want to make sure you don't have any residual regurgitation, and you want to make sure you have acceptable gradients. This is a 3D image of the Intrepid valve. By applying color, there was no evidence of a mitral regurgitation, and the mean gradient was 2. It's important to remember that these TMVR procedures can, the main risk associated with the TMVR procedures is the risk of causing LVOT obstruction. Because when you're doing a surgical mitral valve replacement, the anterior leaflet is oftentimes removed. Whilst when you're doing a transcatheter procedure, the anterior leaflet is usually preserved and can get pushed into the LVOT by the new transcatheter valve. And that's why it's important to have pre-procedural planning by CT to determine the length of the anterior leaflet, the angle between the mitral valve and the aortic valve, because the more acute this angle is, the more risk of LVOT obstruction. And nowadays, we're doing a new procedure called the lampoon procedure, where we lacerate this anterior leaflet percutaneously to decrease the risk of LVOT obstruction pre any TMVR procedures. But this is something to watch for, especially when you're reading the echoes post-TMVR. Look at the LVOT signals, look at the gradients across the LVOT to make sure there's no evidence of LVOT obstruction. PVL closure is another procedure that I believe heavily relies on 3D planning and guidance. This was a patient with a bioprosthetic valve presented with shortness of breath with severe hemolytic anemia and had a TEE which showed 2 paravalvular jets. So you see that this is the surgical frame right here, and the jet is outside of the valve in the paravalvular space. So this patient had 2 paravalvular jets. 3D is very helpful in localizing these jets. Again, this is your aortic valve anteriorly, this is your appendage, and you see 1 jet in the lateral position right here, and 1 more anteromedial. The lateral jet was the bigger jet. So we fixed this one first and reevaluated the smaller medial jet. Again, this is the posterior lateral, and this is the anteromedial. CT is also helpful in planning and evaluation of paravalvular leaks. These defects have a tortuous course, and determining their course and their size can be helpful in determining what closure device is needed for these procedures. What we've also been recently doing, it's a project with Siemens, is using these CT markers to localize the PVLs and applying them, superimposing them on the fluoroscopy screen to provide additional guidance for the operator. So in addition to 3D, we have CT fluoroscopy in the room, because when you're trying to pass a wire into a very small defect, it's more technically challenging compared to positioning a mitral clip, which you can clearly see. So if you have a small defect and you're trying to pass a wire through it, the additional guidance you have, the higher likelihood of your success. So this is what the fluoroscopy screen looked like. And you have the two defects right there marked for the interventional cardiologist. And you can see that we're able to pass one wire through this defect with the use of 3D echo guidance and CT fluoroscopy fusion. Additional things that we can use that are imaging-based to optimize the procedural planning phases, the use of 3D printing using CT or sometimes TE images. You can build patient-specific 3D models showing the different defects, deploying different devices before the procedure so you can know the optimal device in terms of sizing and the interaction of the device with the prosthetic valve that you have. And we commonly do that for our PVL procedures. So this is live 3D guidance. Again, you have the two defects, the lateral one and the smaller medial one. We were able to pass the wires and the catheters into the bigger one, which was the posterior lateral. You see that this is the catheter, and this smaller line right here is the wire. You want to make sure that you cross the defect, because sometimes this wire can go inside the prosthetic valve. So you want to make sure you're in the paravalvular space and not in the valvular space, because you want to deploy the plug in the paravalvular space. So here we've crossed the posterior lateral defect. And then we've deployed a VSD occluder. You can see it here, looks like a mushroom. And this is the catheter attached to it. Again, echo is important because you need to study the interaction of this device with the prosthetic valve that you have. You want to make sure that this device is not obstructing the valve. It's not causing any leaflets to be stuck either in systole or diastole, causing either severe MR or mitral stenosis. So we deploy the device, we check the valve function, make sure there's no interaction with the device, make sure that the regurgitation is decreased before we release the device. And this is after the release of the first VSD occluder. It's well seated, and if you apply 3D color, there's only trace residual paravalvular regurgitation anterior to that VSD occluder. What we try to do next is cross the smaller medial defect. In patients who present with heart failure, any reduction in MR, any significant reduction in MR can significantly help with the symptoms. But for patients who present with hemolytic anemia, you'd want to try to close as many defects as possible, because if you leave small defects, that they can continue to have hemolysis. So this is their lateral defect. This is the medial defect. And you can see that we're trying to wire the defect. This is the deployed plug in the lateral defect, and we're unable to pass the wire through it. Again, these defects are small and have tortuous courses, and sometimes it's really hard to pass a wire through them. But we tried, couldn't fix the medial one, but the patient did well. The regurgitation decreased significantly, and there was no interaction with the prosthetic valve, good gradients, and we left a left to right shunt, which we didn't have to close. Moving on to TAVR. Nowadays, we're using more TTEs in TAVRs. So I'm not going to spend too much time discussing the role of 3D echo, but when we do use 3D, it's I think, visually nice for a post-TAVR assessment. Here we have a TAVR valve deployed. You assess for regurgitation, PVL, and if you see it on 3D, I think it looks much nicer. So this is the role of 3D echo for me. All right, moving on to the transcatheter tricuspid interventions. This is kind of a new field with multiple devices being studied nowadays. We have the leaflet devices. The most commonly used device is the mitral clip in the tricuspid position. But there are also annular devices, coaptation devices, and transcatheter valves. The most commonly used one, as I said, is the mitral clip, and that's the one we've had experience with so far, but we're enrolling in a couple of new trials, so stay tuned. I'll show you the role of 3D echo in tricuspid interventions, because unlike the mitral valve, I feel like the tricuspid valve plays hard to get. It's hard to get nice 3D images. It's hard to know which leaflets you're grasping, so 3D echo can be very helpful. This is a patient with severe tricuspid regurgitation. This is the mid-esophageal short axis view. Transgastric views are very helpful for tricuspid imaging, because with the short axis views, you see this is a tricuspid valve. This is your septal leaflet, anterior leaflet, and posterior leaflet. Again, with 3D, this is your aortic valve. So whatever's close to the aortic valve is going to be your anterior leaflet. This is the septum, this is the septal leaflet, and this is the posterior leaflet. Applying color, you can tell that the jet is mainly coming from the gap between the anterior leaflet and the septal leaflet. So ideally, you'd want to place a clip right here to decrease the amount of tricuspid regurgitation. This was the initial clip position. You can see it's angled towards the posterior leaflet, but we wanted to deploy it at this junction right here, anterior and septal. So under 3D guidance, again, that's why 3D is very helpful. You ask the interventional cardiologists to move the clip more anteriorly and medially towards the septum, and then you ensure that the clip is positioned at this, the gap, the coaptation gap. You confirm this on 3D, and then you deploy the clip. And again, this is the mid-esophageal biplane view. This is your transgastric view, and you can see that the clip is deployed at the septal leaflet, anterior leaflet junction, and that's where you're seeing the most regurgitation. Again, you reevaluate with 3D and 2D, and the patient continued to have significant TR. So the plan was, we have a clip right here, anterior septal. The jet was coming from the anterior, posterior portion now. So we positioned the second clip. I don't know if you can see it well. It's right here, and it's going between the anterior leaflet and the posterior leaflet. So this is clip number 2 being positioned, and this was our final view. We have a clip going anterior, posterior leaflet, another clip septal to anterior. You can see this on the transgastric views. This is your clip going septal to anterior, anterior to posterior, and there was a significant reduction in tricuspid regurgitation. Lastly, 3D and echocardiography in general is very important in detecting immediate post-procedural complications. It's important to monitor the patients continuously during these long procedures. Sometimes they develop effusions, sometimes they develop device embolizations, shunts. So with any hemodynamic change, you have to re-image and make sure you're not missing a life-threatening complication. This was a patient who had transcatheter mitral valve and valve. For these procedures, because you have to advance the transcatheter valve through the septum, you do a balloon septostomy. So you put a balloon through the septum to dilate it. This patient has significant TR. So in the setting of significant TR and an atrial septal defect, the patient developed this bidirectional shunt and developed hypoxia during the procedure. Based on that, the decision was to close the septal defect. And again, this is an iatrogenic ASD caused by this balloon that was placed during the mitral valve and valve procedure. So this is your balloon septostomy. And if you do 3D imaging of the septum, you notice that the defect is irregular shaped, and 3D can be very helpful in sizing it so you know what closure device to use. So in that case, we used one of the Implanzer devices. You see the deployment of the atrial disc, followed by the deployment of the ventricular disc. You do a tuck test, make sure it's stable. And again, this is a 3D image of the closure device in the RA. You apply color, and there's only trace residual shunting. The patient did not, the oxygenation improved. The patient did well, and there was no issues. Lastly, I just want to leave you with these 2 papers that were published last year relating to structural heart disease imaging. One was the CT, use of CT in TAVR, which was published by the Society of Cardiovascular Computed Tomography, and the guidelines for evaluation of valvular regurgitation after percutaneous valve repair or replacement. That's all I have for today. Thank you.
Testing, testing. Can you hear me?
I can't.
Can you hear me?
Dr. Q?
No.
Test, test.
Okay. So it's on, but nothing is happening. Hello? Testing. Not working? Perfect. Okay. So, first of all, wonderful lecture. Thank you.
Thank you.
I know this takes time to prepare. Two practical questions. One is when you guys are there in the middle of the hit, are you using more real-time 3D or are you still using the biplane where you put the area of interest and zoom to 3D? Which of the two are you more likely to use during these procedures?
Zoom 3D.
So you're still using the
3D zoom.
the biplane creation of the two areas of interest and switching to, okay, so the problem with that one is that any little movement of the probe, you're out of place. So how do you stay in place? Because that's not so easy. I mean, in real time, you can correct very quickly, but once you do that, any
That's
little
very-
movement, you are out.
That is very true. So different steps of the procedure require different fields of view. For example, if you're positioning the clip next to the valve, you just need the valve. If you're guiding the catheter from the septum into the mitral valve, you can use a larger field of view. What we do usually is we get a big field of view, and if the patient moves, you can actually change, we adjust the probe while still on 3D. So we don't always reset back to 2D. So you kind of adjust the depth of the probe, go lateral or medial, and you get back to your field of view while you're doing it live on 3D, rather than switching back and forth to and from 2D.
And of course, that has its own learning curve.
Yes, definitely.
The second practical question is color. Normally in the lab when we're doing TEs and we switch to 3D color, it's not always that clean. So two things. Tips, what do you guys do to enhance the color? And second, what is in the horizon for new developments that will make the color better? Because I think the color 3D still is not ideal, let's put it this way.
I agree with you. Optimizing it mainly, if the patient's in AFib, you want to do HVR, you want to increase the number of beats to get higher resolution. But what I find it to be most useful is when you have a pathology, you want to see where the regurgitant jet is coming from. Post-processing in terms of calculating a vena contracta area is a useful application. But I do see how it's not as clear-cut or clear when you're just using 3D color. I think it shows you the location, the extent.
So again, when you're in the middle of the hit, with the interventional cardiologist asking you, how good does this look? Are you relying more on 3D or 2D?
Both. But I would say 3D for localization, 2D for quantification for now.
Okay.
Nadeen, that was really nice.
Thank you.
Are you using, I'm going to take just the mitral valve clip, residual mitral regurgitation color, pulse Doppler in the pulmonary vein, certainly very easy and very helpful, and prognostically looks like important. But for the residual MR, some labs are using 3D vena contracta, just like flipping it, measuring it and just have a feel for it. Are you using that routinely when you see it or not?
I think we use it when it's not very clear. Sometimes when you can tell that the MR is mild, you have your predominant systolic flow in the veins, an increase in LVOT, stroke volume, and you have your invasive hemodynamics as well. So they can tell you how much reduction in LA pressures you're experiencing, and that's very useful in the cath lab. So you communicate with the interventional team, and they can give you a direct LA pressure, and you have your baseline. You can tell how much reduction you have. But I guess when you have multiple jets or eccentric jets, then you might add that to your tools in the cath lab.
And in your quick hands nowadays, how long does it take to measure it?
A few minutes to center it and make sure you have the right view and you're getting it at the right angle.
Worth the wait, maybe.
Yep.
All right, Nadeen, very nice talk.
Thank you.
Just a quick question. Radiation exposure, I know the cath labs are not designed for you guys to be there. And I know Steve Little used to glow in the dark for a while, but have they optimized the room somewhat to try to reduce the radiation exposure for the imager?
That's a great question. We try to work with what we have. So we have radiation skirts at our side. We have radiation pads that actually go on the patient. So it goes on the patient's chest and blocks the radiation coming from the radiation source. So we use these two things. And again, when you're not needed, you're not actively guiding them, you can step back because distance is your friend. But for now, it's the radiation shield, the radiation skirts that we're using, and heavy lead. And it's important for interventional images to make sure that their lead is uniformly thick. So my back is as thick as the front side, because ideally the back is usually lighter to help with, because when you're the operator, your back is not exposed. But when we're standing at the left side of the patient, sometimes we have our back to the radiation source. So the lead has to be uniformly thick, glasses, caps.
Are you measuring radiation?
It's been okay. Again, the use of 3D, I'm alive. No, it's
for the imagers to do.
we monitor them monthly, and honestly, when you're heavily relying on 3D and 2D echo guidance, the amount of fluoroscopy you need decreases significantly.
Where do you place the badge on your neck? Or
No, here in the pocket, front pocket.
because you probably want to get it as close to the radiation source as possible.
All right.
Thank you.